Both simple and combined procedures are common in endourology. Antegrade access is ideal for the management of urinary tract anomalies. We reported 3 unusual cases of lithiasis in patients with previous lower urinary tract reconstruction or urethral stenosis. This is the case of a female patient suffering from recurrent urinary infection. She presented with left kidney and distal urethral stones. She had permanent percutaneous nephrostomy tube and double J stenting since 2010. She was not fit for retrograde flexible ureteroscopy. We reported the endoscopically extraction of right urethral hallium stent after 2 years of indwelling also. Mucosal regrowth inside the lumen and mild encrustation are clear. Taking advantage of previous nephrostomy after antegrade pylography, we perform an X-ray second kidney access in supine position. The puncture was done at the level of a medium calyx, ideal for flexible antegrade procedures. After the placement of mini-percutaneous coaxial access, laser lithotripsy with flexible ureteroscope was performed. Ureter and kidney were stone-free at the end of the procedure. The second case is a young woman with a complete cloacal sinus and colonic agenesis at birth. Immediately, she underwent a bilateral cutaneostomy and ileal rectum reconstruction. Some years ago, she was converted, after an ileal conduit, to an ileal continent reservoir with Mitrofanov of 2 umbilicus. She was admitted in intensive unit care for sepsis twice in the last years. She developed stones in both kidneys and reservoir. After a cystogram through the Mitrofanov, the exploration of the reservoir under flexible ureteroscopy failed due to twisted way. We decide for an antegrade percutaneous access through the left kidney, which looked like the best choice due to the anatomy of the calyx and the thickness of the cortex. Under ultrasound-guided puncture to the upper calyx and an injection of contrast medium and a mini percutaneous balloon dilation, the access was placed. The progression of flexible ureteroscope to the reservoir made it possible also to enter in the pelvis of the right kidney afterwards. It began a first time of laser tripsy. After 1 week, a second percutaneous look was performed with a larger access to 24 French, thus allowing the exploration and laser lithotripsy through a flexible cystoscope. CT scan at 6-month follow-up showed a complete removal of stones in the left kidney and in the reservoir. The last case is a 7-year-old girl with Wachtel syndrome who previously underwent several reconstruction and plastic surgery. She developed a 1.5 centimeter stone in the left ureter. She was booked for flexible retrograde approach versus percutaneous nephrolithotomy. We first tried with a flexible retrograde approach through the appendix conduit. Although the access was not difficult, the stone burden and the need of multiple basket fragments extraction convinced us to perform a mini percutaneous combined intrarenal surgery approach. At the end of the procedure, the patient was stone-free. In some special cases, where it is not possible a standard approach for solving lithiasis disease, the versatility of endourologists allow original and effective solution.